From Robert Wood Johnson University Hospital, this is Medically Necessary.
Welcome to Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff. I'm Chris Hoenig, joined as always by Dr. Jim Salwitz. Dr. Salwitz, it's a new day for you. It's now 2021, and you are no longer our medical staff president.
No, I'm trying to get over it. I am wandering the streets a little bit, Chris, et cetera. It's going to sound pathetic, but I will get over this. I will.
Well, there was all this back and forth during the presidential campaign about, which candidate was hiding in his basement. And, your White House, your Oval Office, which is rectangular, but, kind of in the basement of the hospital, it feels like sometimes, right? A little bit of a dungeon down in the med staff office, it feels sometimes.
Yeah, now I'm just out among the little people, if you will, Chris, and I'll try to get over it.
Well, and much brighter part of the hospital, certainly bright in terms of aesthetics and feeling these days, is the courtyard, the vaccine clinic that has taken over the courtyard at Robert Wood Johnson University Hospital. Very exciting times. In the first week, we had over 100 clinicians go through there just during the soft launch. Now up over 200 people a day able to get their vaccines at the hospital. It's really exciting. It's that light at the end of the tunnel. Certainly can't forget to trust our PPE, trust our cleaning processes in the meantime, but there is that light at the end of the tunnel. It's
really a very exciting moment. And I think the hospital staff, the professional staff, the leadership, Bill Arnold, the Stockman, have done an incredible job in rolling this out. And it is really a wonderful new moment in the battle against this disease.
Well, and with that, I'd like to welcome our first guest today from Rutgers Robert Wood Johnson Medical School, Dr. Jeff Carson, internationally renowned expert in blood medicine, and somebody who has been carrying on our important mission, that academic mission here at RWJ. And so, Dr. Carson, first of all, thank you for joining us today. It is a pleasure to have you with us.
Hi, Chris. Hi, Jim. It's a pleasure to see you, and thank you so much for inviting me.
You've been a great you've been here before. We really appreciate your education and your guidance. So thank you again for the time. We really do appreciate it.
And before we get into your research, we are talking about the vaccines that are out there on the market now. We're giving the Pfizer vaccine here at RWJUH. The Mrna vaccine has also received its EUA and is being distributed throughout the country. These mRNA vaccines, both 95% roughly efficacy. This is a leap in vaccine technology, is it not?
Well, the efficacy is remarkable. And, if you review the trial data, and the Pfizer trial was published in New England Journal of Medicine a few weeks ago, it's amazing. 2 weeks after the second dose, and this is a 2-dose vaccine, 2 weeks after the second dose, the curves related to developing COVID in the group that got vaccinated was totally flat. There were no new cases. And it's a great vaccine. And, you don't see vaccines that have this level of efficacy. It's quite remarkable. In fact, Chris, Jim, guess what I did this morning? I put my arm out and I got the vaccine in the courtyard today. And I'm grateful for the opportunity to receive it, because I have no doubt that it's going to reduce my risk of getting sick, my family's risk of getting sick, and I certainly would encourage all my colleagues, and certainly our community at Robert Wood Johnson University Hospital, our nurses and our support staff and everyone else to go get that vaccine. There's great data, and it's going to protect you and your family. I strongly urge you to do that.
And congratulations on getting the vaccine. And then, thank you very much, Jeff, for that kind of guidance and that support, because it's so important that we get the word out and get this done.
Yeah, it is. Now, you guys might be interested, because you probably know I'm leading the Johnson & Johnson vaccine trial here at our hospital and at Rutgers. And that trial will probably report out sometime third week or so in January. We've enrolled 45,000 people worldwide, which is really quite remarkable. And, I'm proud to brag a little bit that we were the second highest recruiting site across all 200 plus sites in this trial. We had enormous cooperation and enthusiasm from our community, and we're certainly grateful for that. And we'll see, how good that vaccine is compared to the others. It'll be very hard for it to be any better, but hopefully it's just as good. And because it's one dose, that would be a huge advantage if it turns out to be as good and safe as the other two vaccines.
Very exciting moment and change in time. Now, unfortunately, Jeff, as we're all aware, we are still treating a large number of patients, with this illness, and even the most optimistic projection says that we're going to be doing so for months and months to come. And while obviously prevention, goes a long way, we do need better therapies. And I gather you've now rolled out a trial to look at what we don't have basically any of, which is treatment modalities in the outpatient setting. So what it is are you working on now?
So Jim, as you know, and as was introduced, my research world up until COVID was transfusion. But I've been working with Marty Blazer and Ray Panettiere, and we've been doing multiple studies in COVID. And we had an opportunity to lead a trial which we call TriACT. It's TriACT. And so this trial is geared towards the outpatient who's not sick enough to be in the hospital, but has newly diagnosed COVID. And what we normally do is we send these people to bed, right? We send them home, we ask them to quarantine, but we don't offer them much in the way of treatments. There is some intravenous treatments that are available, but this is an oral treatment, 3 medications, and the goal here is to see if we can establish whether it has efficacy. That is, it reduces viral load, and hopefully if the trial can get done in a larger number of people, that we can show that it reduces the risk of people getting sick, of getting hospitalized, and maybe even preventing spread of the disease to their family, to their friends, and to their community. So this is a pilot study. It's a 70-patient trial where we try to recruit people who are just newly diagnosed. So they have to have a test within 7 days that's positive for COVID. And then we bring them in, we do a bunch of blood tests, we do an EKG. Obviously, we ask them, we tell them all about the study and they sign consent. And then we randomize them. That means we flip a coin, of course, and half the people get a 3-drug combination and half the people get placebo. The way this works is that we then ask them to swab their nose 3 times over the next 10 days, 3, 6, and 10 days, and we measure the amount of virus in those swabs. And the basic idea here is, do the medicines that we give them reduce the amount of virus more rapidly than people who get placebo? So it's a placebo-controlled trial. You might be interested, of course, to know what are the 3 drugs. And so one of them is called natoxamide, the other is ribavirin. And then the third drug, which is, I think, one of the controversial things about this study, unfortunately, is that famous drug called hydroxychloroquine. And we're using that 3-drug combination based upon laboratory data, Jim, that shows that you can suppress viral replication of this virus with the 3-drug combination much more effectively than 1 or 2 drugs alone. And when you combine all 3 drugs, you have a 4,000-fold reduction in the amount of viral replication. And by adding, the hydroxychloroquine, which some are quite concerned about using, it has an 8-fold higher effect on reducing viral replication. So, that's why we're doing the trial this way. Your patients only need to be with us for 30 days. We see them 3 times in the office, first time, and then at 2 weeks and at 28 days to see how they're doing. We're following their blood tests, we're following their EKGs, and obviously we're available to them, and if they were to get sick or have any problems. So it's called the TriACT trial, and we'd love to get some referrals from our colleagues for their newly diagnosed COVID patients.
How do you get a patient signed up?
So we have a website, we have a telephone number, and we have an email address. Any one of those things will work. My research coordinator is holds on to the phone 24/7, although please call her during the day, and and then she will tell your patients about the study, give them an overview of it, email them the consent, and then if they're interested, then typically we'll bring them in the next day, and then move forward with the trial.
So Dr. Carson, with your triple combination antiviral coronavirus therapy, the TriACT study, obviously very important because, when you are feeling very sick, when you are experiencing those symptoms, it's easy to stay in bed. It's easy to stay away from your family. When you're maybe not symptomatic or just mild, you do tend to have that kind of different peace of mind, maybe that, I'm not that sick. I don't need to worry about getting other people sick. So this is very important in that perspective, certainly. You had mentioned the hydroxychloroquine. We had seen all the trials that had gone on early on in that first surge of COVID on hydroxychloroquine. Is the dosing different since it's being used in combination with other drugs?
It depends on the trial. It's approximately the same dose, but we're only giving it for 5 days, and we're monitoring. Everyone's getting their EKGs are being monitored, so they're being very, very closely monitored. I think the trials that have been done were either done with hydroxychloroquine alone or with azithromycin. Okay, they were all negative trials. They did not show efficacy, and when we were putting this trial together, we said, well, why are we going to use a drug that everyone's going to look at and say, oh my, why are we doing this based on this prior data? And the answer, once again, I'm coming back and re-emphasizing, this synergism with this drug plus the other two is so significant that we think the 3-drug combination is likely to be highly effective. But let me get back to a point you just made a moment ago, Chris, because I think it's a really important one. When people don't feel particularly bad, they're asking, well, why should I take any medicines? And, that's not an unreasonable point of view. The argument to do it is that some of those people will progress, where they'll begin to get sick. Not too many of them wind up in the hospital, thank goodness, but some do. And then, the hope is if you kill this virus, then you're going to be less likely to transmit it to those around you. So that's the other argument why this kind of treatment could be so important. Because remember, so much of the transmission of this disease, and the reason why it's been so challenging, one of the many reasons why it's been so challenging to control, has been that people have either mild or no symptoms, yet they're transmitting it to their friends, family, and others. So those are the reasons why we think this makes sense. We think this drug combination will be well tolerated. It's only 5 days, so it could be a game changer if we can get some folks interested in participating.
Jeff, who's not eligible for the trial?
Well, anyone who's hypoxic, anyone who's obviously admitted to the hospital, anyone who's short of breath. Those are, and then pregnant. Anyone who's pregnant wouldn't be eligible as well. That's largely the exclusions, and then there's lots of other little things, but those are mostly very uncommon.
Fascinating. That was a great trial. Other studies that you're looking at opening up in the near future? What other research ideas do you have going forward here, Jeff?
Well, so I'm doing the ensemble trial. I'm doing this trial, right, of course. And then I'm still doing my transfusion, my MINT trial, our transfusion trial on acute myocardial infarction. So as they say, my cup runneth over.
You got to start backing off, really. Really.
But the team's involved with many studies. So Ray Panettiere is doing a trial in hospital with a drug that he hopes will prevent respiratory complications. We're doing cohort studies where we're still following, if you recall, what we call the RCC, the Rutgers Corona Cohort Study. That's 800 plus people. We've been following them now since March, and we're probably going to do another evaluation in that group to see what happens with the frequency of antigen and antibody positivity, their symptoms, and looking at the correlation between that and developing disease. There are a whole bunch of other studies that are under planning and being considered at this point, Jim.
Very exciting, really exciting, and it's so much what this institution is supposed to be doing at this time. I mean, we are, obviously we are a treating institution, a clinical institution, but we are at our soul an academic institution, and this is our function, and this is what we should be doing. So we're really thrilled by your leadership, and your work during this time. It means a lot to a lot of people, and not to mention the institution itself. So thank you so much.
Thanks, Jim. The medical community has really risen to the occasion, and this has been so difficult. So many of my colleagues are putting themselves personal risks, of caring for these people and who have been so sick. And, and I think, the second wave is a bit frustrating for everyone, because some of it, of course, is because maybe our community hasn't been as careful as we would have liked, and maybe some of the political leadership around the country hasn't been as forceful in pushing the use of masks, the use of separation, not getting together in big groups, and so forth. And so I would also urge, of course, our whole community. We're still highly vulnerable. That people follow those very basics of 6 feet away, of washing your hands, of wearing a mask, that, we're not out of the woods yet. And while these vaccines will have the potential to get us a long ways towards that point, we have a long ways to go before we're there. So no one can let their guard down, must keep working at this. And, I so much admire our colleagues who are taking care of all these sick patients in the hospital. They're doing a great job, of course, and doing it with, putting themselves a little bit at risk. So
it is a time that is in the finest tradition, of our profession, and the people our society owes them a long-term appreciation and thanks. So you're 100% right. Couldn't agree with you more.
And, I don't know, I'm so impressed with the quality of what's going on, of the care that people are getting here, and the enthusiasm of our teams in trying to take the very best care of our patients here. And so I'm very proud to be part of this whole organization.
Absolutely. 100%. Thank you so much.
Dr. Jeff Carson, thank you so much for joining us today, really highlighting that academic mission, that ongoing research, the amount of research that we've been doing here. Of course, your studies, the surveillance study, one of the largest surveillance studies of healthcare workers in the country during COVID-19. So really just incredibly important work that is going on here at RWJ. Dr. Jeff Carson, thank you so much for the time.
My pleasure. Take care, everyone.
And of course, the need to continue wearing a mask, social distancing, washing your hands, very important as we work towards the vaccine. Also, that need to trust our PPE, trust our cleaning processes. We'll get into that coming up right after the break with Dr. Bruce Haffty and Dr. Andrew Evans. We'll be right back.
You know those times when you need to see the doctor, but you just can't get to the doctor? So where do you go? Go to the App Store, download the Telemed app from RWJBarnabas Health, and you see the doctor right away. From any mobile device, whenever you want, wherever you are.
Quality care, no appointment necessary. The doctor is online when you download the Telemed app.
Don't you feel better already?
RWJBarnabas Health. Let's be healthy together.
Medically Necessary, the official podcast of the Robert Wood Johnson University Hospital medical staff.
Welcome back to Medically Necessary. Chris Hoenig here with Dr. Jim Salwitz. And Dr. Salwitz, that interview we just had with Dr. Jeff Carson really highlighting the importance of the academic mission during a crisis like COVID-19.
Right. I mean, the research that he was referred to in our interview, the expansion of research in general, of course, the institution, our ability to step up in a crisis like this. I mean, it's very exciting to see this institution perform at its highest level, at a time it's giving critical clinical service, but also going a great deal to further the knowledge base across the country, across the world. It's kind of very exciting, really. It's kind of made you very proud of this institution at this time.
Definitely is. Research into inpatient therapeutics, now research into outpatient therapeutics, surveillance research of healthcare workers. And we've also had research going on here at our institution into surface contamination by the virus that causes COVID-19. And I'd like to welcome our next guests right now, Dr. Bruce Haffty, our Chief of Radiation Oncology, and Dr. Andrew Evans, who is the Medical Director for the Oncology Service Line for RWJBarnabas Health. Dr. Haffty, Dr. Evans, thank you for joining us today.
Thank you.
Good to be here.
So, Dr. Haffty, Dr. Evans, you two have run studies in conjunction with one another, looking at the surface contamination from the SARS-CoV-2 virus. Dr. Haffty, you started out with the study in the radiation oncology spaces. Can you tell us a little bit about your work?
Sure. Thank you. Well, first of all, building on the academic mission that you were talking about earlier, it's really important that I acknowledge Mrna John, who was really a junior resident in radiation oncology, who initiated these studies. In academic medicine, in addition to trying to deliver the highest quality of patient care and cutting edge care, we have a mission to move the field forward with research. And Imran came to me really at the early part of the pandemic with a concept where he wanted to test the surfaces because there really was no data in oncology clinics and radiation clinics. And that was very important to our patients because at the time, Robert Wood Johnson, as many other hospitals in the state, was being filled with COVID patients. And patients who come for daily radiation were concerned about coming into the clinic, wondering if they would, be exposed unnecessarily to the virus. And of course, the patient's calling in concern, but we can't deliver radiation on outside of the hospital. We don't have the option of telemed for delivery of radiation. So it was important for us to address that question. And I thought Imran's idea was great. And so we worked together. He really laid out the research plan, part of which was using the already available WHO, World Health Organization, protocol for testing surfaces, worked out all the details, collaborated with our lab at Robert Wood Johnson Hospital to make sure that they could do the appropriate testing on that on the surfaces, worked with some of our environmental health specialists at Rutgers, and came up with a nice plan of testing the commonly touched surfaces by our staff and patients, bathrooms, areas, and radiation machines, etc., changing areas. And over a course of 2 weeks, during the height of the pandemic in New Jersey, tested the surfaces and found no surface contamination. That was a very important message to our patients. And as you know, subsequently that was published in JAMA Oncology and actually became a source of information for radiation clinics throughout the country that they could reassure their patients that coming in for daily radiation, as long as we used our usual strategies of distancing, masking, and regular cleaning, that the area, at least the surfaces, were safe, free of COVID, even in this heavily trafficked area during the peak of COVID.
And so, Dr. Haffty, you tested approximately 120 or so surfaces, found 0 incidents of the SARS-CoV-2 virus. And then, Dr. Evans, you ended up testing approximately 200 surfaces, and your study came up with 1 positive. Is that right?
Chris, that's right. And just further drill down, I mean, part of the reason this research was important is there was prior data published actually in the New England Journal that the virus that causes COVID-19, SARS-CoV-2, could be viable for up to 72 hours on surfaces, plastic, metal, cardboard. So there was a concern. The issue with that study is it was somewhat artificial in a laboratory. It wasn't a real world. So Dr. Haffty's work was critically important. And as you said, we really just dovetailed on that, but we took it over to the hematology oncology outpatient and inpatient spaces, again, using the same methodology that they had used, where we were testing for SARS-CoV-2 RNA by real-time PCR. But we looked at we tested 140 surfaces over a couple-week period. Again, this was back a few months ago when there still were quite a few cases in an outpatient hematology space and an outpatient oncology space. where patients are treated, evaluated, and then also 2 different inpatient areas. One was an area where we treat our leukemia, lymphoma patients. They receive CAR-T therapy. And then actually also an active COVID-19 unit, or what's called a PUI, patients under investigation. So if our patients were positive, they would go to this unit. And what did we test? We tested high foot traffic areas and high touch areas. So in the public areas, we tested surfaces in waiting rooms, infusion areas, bathrooms, floors, elevator banks, exam rooms, etc. We also tested staff areas, computer equipment, tubing stations, pharmacy, medication rooms, and then we also tested different medical equipment that our patients and staff use, like IV poles, chemotherapy bags, telemetry stations, linen carts, etc. I should just also highlight on the outpatient spaces, there were a couple active COVID patients that we were treating. It's not common to treat during COVID. There are a few extenuating circumstances, some high-grade lymphomas, leukemias. And so despite that, in all of the outpatient spaces, 0 of 140 surfaces were positive. On the inpatient side, there were a little over 70 surfaces sampled. On the CAR-T leukemia lymphoma unit, 0 surfaces positive. From about 30 samples on the COVID unit, there was 1 positive sample. It was on the floor of a very sick COVID patient that was positive. So altogether, that was 1 out of 204 samples, so less than 1%.
Really remarkable, and obviously very reassuring for everyone that in these units, using proper cleaning processes, we are able to keep staff safe, really, patients safe by cleaning these services, et cetera. And as I recall in your studies, you actually deliberately did testing well away from recent cleaning cycles, so that it would be at the nadir, if you will, of protection.
Right. I think it was an important point that we did, and Andy's group did the same thing, in that we kind of did this under the radar. We didn't do anything special that we don't do normally. So the staff didn't even know what we were doing. They went, once in a while they say, why is this people coming around and, swabbing the surfaces, whatever. But they did not know. So they were doing their routine care. They weren't going out of their way for extra cleaning. And we did the sampling before the nighttime cleaning crews came in. So that was important, in that we weren't doing anything out of the ordinary, and the staff was literally not aware of what was going on. This was all obviously also approved by our institutional review board. So those things were important points of both studies.
So, this research doesn't address this question per se, but I'm curious if you guys have a gut feeling or a hypothesis. What is cause and effect here? Is it that the virus is not that easily contaminating surfaces, or is it that cleaning functions are that effective when done properly? Any feeling? I guess that's an important question when people are in their homes or getting food delivery. Do we have any feeling at all of where, what it is that we're seeing here?
Yeah, I would say it's probably both, Jim. That's a good point, that it probably is a low risk of it. But the fact that we did pick up that 1, despite all of our good practices, does tell us it may be possible. Now, we just picked up virus. That doesn't mean it's transmissible on the floor there. I think it's still very important for the public and everyone, frankly, to realize, yes, the primary mode of transmission is airborne. And so, of course, even as we're going through vaccinations, it's still critically important for social distancing, masks, etc. But all of those are probably important. Everything that RWJUH, just instantaneously put in all these measures of visitor restriction, PPE, social distancing, disinfection. We quickly leveraged telemedicine. I think all of that has helped really mitigate the risk.
And it's been very important, not only the patients, who now we can say, well, when they call concerned about coming in, we'll say, well, we did these studies and we've shown that our surfaces are clean as long as we take our usual precautions, but also very reassuring to the staff who are working every day in this environment.
I think what you're also going to see, and maybe this will be a future interview for Dr. Labuti, our center director, he's been helping lead research. We're testing a lot of asymptomatic patients through the usual nasal testing, rapid and PCR. And not to minimize any of the surges that are ongoing now, but in all of our asymptomatic, and this is hundreds of patients over the last few months, literally less than 1% of patients, of our asymptomatic cancer patients, have tested positive. Now, I think that's a select set because these patients are more cognizant and they're all mask wearing, et cetera. But I think if you're doing the right thing, it really tells us surfaces and even airborne, the risk is quite low.
And I think that's an incredibly important lesson because despite the excitement of having the vaccine, it will take us months and months to vaccinate a gigantic sum of the population in order to achieve herd immunity, be able to feel more comfortable not doing these things. And so that's the important point going into the new year, if nothing else. These things work. We can keep each other safe, do them, and we'll get through this, together. So, it's so important. And by the way, I would be remiss if I didn't mention, the whole EVS team, all the clean team at the hospital, which has been such critical caregivers. This is Rusty Catala's group, and they've done a massive amount of job, on the front lines, making this possible. So that we have to remember to thank all of them for their very hard work as critical caregivers themselves.
And I just want to put in one last plug for Imran, John, and Dr. Shah from Andy's group. These are the fellows, the trainees that are looking for projects. And in this case, they actually conceived of the project. So just a plug for our trainees.
And as we give them their credit, of course, and highlight some of the academic work that happens here, one of my favorite stories, we were all chatting yesterday and we touched upon this. Dr. Evans, when you joined our staff about 3 years ago, Dr. Salwitz popped into my office immediately after his interview with you when you first received your privileges at the hospital. And he was like, I know I recognize his name from somewhere. And it was because he had just read an article that you had published in one of the journals. Dr. Salwitz, you now remember the article, right?
I moved, and as Eddie reminded me, moved to use that therapy on a patient that I was presently treating. So I mean, that's it's all of a thing, if you will. That's what this institution's about.
It's a small world and meant to be. Yeah, it was a elderly or older Hodgkin lymphoma patient. We had just published in Bruce's journal, he's the deputy editor for JCO, an article about using a targeted agent. So that's great that we could help and work together in any way.
Outstanding. So thank you, gentlemen. Wonderful work at the finest example of this institution and what it's capable of doing, particularly in a crisis. Really very exciting.
Dr. Andrew Evans, Dr. Bruce Haffty, thank you so much for joining us today.
Thank you.
Thank you so much.
As always, you can subscribe to Medically Necessary on your favorite podcast platforms. You can find us on Apple Podcasts, Google Podcasts, Spotify. We also have a link on the Robert Wood Johnson University Hospital Medical Staff Portal, and we are available through YouTube. For Dr. Jim Salwitz.
For Chris Hoenig, Happy New Year, by the way.
Happy New Year, and thanks for listening.
Medically Necessary, brought to you by the Robert Wood Johnson University Hospital Foundation.